Guidelines to patient-centered care. So, four key strategies for engaging patients and their family and the caregivers while deciding for the care treatment or care plan for your patients. The first thing, self-managing health and health condition. This involves support for developing knowledge, skills, and confidence to manage one's own health. That is self-care and caring for specific health condition, recovering from an episode of ill health. For example, a stroke patient after just before discharge, self-managing health education will be given in terms of diet, physiotherapy that they have to follow. So at home they can follow all this and they can do their self-care as well. Shared decision making that supports the patient. It means patients including the patient include the patient in taking decision about their health, in considering options, including the choice of making no options. If they don't want to do the treatment, they have the choice not to continue with any treatment. And to check the risk benefit analysis, the patient can make the decision on that. So that is the shared decision making that supports the patient. Peer-to-peer action, support the patients in providing and receiving help from others who have suffered from the similar conditions, and it is based on mutual understanding and shared experiences. They feel good when they are in a peer-to-peer actions group. Support the families and caregivers. So here it seeks to develop knowledge, skills, and actions enabling the people who care for the sick care for themselves also, and to give them emotional support to care for the patient. So that is support for families and caregivers. Improving the patient satisfaction. Foster a culture of friendliness. Here, the importance of a positive communication is being stressed, and empathy towards the to improve patient satisfaction. This culture of friendliness should not be limited to the healthcare providers, but it should extend to all the hospital support staff also. And implement and enforce hospital policies that benefit patients. The policies of hospitals, for example, the noise policy, the visitors policy, okay, these things should be implemented in such a way that it encourages patient satisfaction. So all the hospital policies, directly or indirectly, that benefit the patients should be implemented. Keep hospital spaces neat, safe, and clean. And just to prevent, ideally it is done to prevent any spread of infection. It is important that hospital leaders ensures a clean, safe, and neat environment for the patients within the hospital. Include patients in the hospital design process. So for example, taking their options, taking their opinions in terms of parking space, etc. Okay, the patient parties concerns about the parking space, the food services within the hospital, how to improve, do they have to improve anywhere, etc. So this is how you include the patients in the hospital design process. International patient safety goal. The first goal is identify your patients correctly. You have to identify the patient as a person to whom the service treatment has to be given. Cross check the patient name, patient IP number, barcode, date of birth, etc. to be sure. And the service you are going to give to that patient, it should match that patient. Next is improve effective communication. What happens here is the process of reporting the critical results of your patients, that has to be enhanced. The process of handover communication should be cleared. The handover communication may take place between health practitioners, between different levels of healthcare, from primary to secondary, secondary to tertiary, and it can take place between the inpatient units and other departments like radiology, pharmacy, laboratory. It can also take place between the patient family members at the time of discharge. So improve effective communication in all these areas. Improve the safety of high alert medication. While prescribing a high alert medication, cross check if the patient is allergic to that or not. Before administering high alert medications, cross check the patient name, cross check their date of birth. Do check if the same name patient is there in your ward or not. Check their barcode. Is it same for the prescribed high alert medications? So these all things should be double checked before administering the high alert medications. Ensure safe surgery. pre-operative verification should be done, correct site verification should be done, surgical site marking should be done, site cleaning should be done before the surgery, time out checklist should be filled up when the from the start of the surgical procedure to the end. Sign out checklist should be filled up and conducted after the procedure before you admit the patient from OT to the post-operative ward. So these are the steps that you should ensure during safe surgery practices. Reduce the risk of healthcare associated infection. The hospital has to reduce the risk for HCI from one and the foremost important thing, that is hand hygiene. Follow hand hygiene given by the WHO and according to the CDC guidelines. It should be ensured that all the staff, healthcare staff, complies with the hand hygiene protocols of the hospital to prevent healthcare associated infection. Reduce the risk of patient harm resulting from the falls. Check which patients are prone to falls. The patients who have previous history of falls, who are on some medication, alcohol consumption, who have vertigo issues or gait or balance issues, and altered mental status. The patient who are in altered mental status, these are the patients who are at risk of falls. So make sure you keep observe these patients carefully while when they are admitted. Make sure your floors are slip-free. Your toilets have handrails to grab onto when the patient feels like falling. Okay, so these are the things you have to keep in mind for international patient safety goals. Spectrum of services. It starts from the admission to the discharge. So the first, the foremost, admission into the hospital. Hospital should process admitting. There should be a process for admitting the inpatients, for registering outpatients. Patients' need for preventive, palliative, curative, and rehabilitative services should be addressed, and according to that, priority is given. Priority-based admission is done, and at the time of education, health education and orientation to the family members of the patient is given about the ward, where the toilets are, if it's a general ward, what is the food timings, what are the visitor timings. Everything is educated during this step. The second is continuity of care. Before the treatment, before commencing the treatment, during the treatment, and even after the treatment, before discharge, continuity of care is ensured. From all the different qualified healthcare practitioners, the healthcare team from their respective areas, they will take part in the continuity of care of the patient. Information transfer. The information is transferred from the patient's care. It should be transferred with the patient and the other healthcare professionals, as and when required, maybe to the caretaker also. Discharge, referral, and follow-up. The process of referral and discharge of the patients is based on the patient's health status, current health status, their need for continuing the care of services in that particular hospital, and the patient and the family education and instruction should be related to the patient's continuity care needs. So that is just discharge, referral, and follow-up. Discharge summary and medical records. A complete discharge summary should be prepared for all the inpatients at the time of discharge. Incomplete discharge summary is not accepted. All the medical records of the inpatient should contain a copy of discharge summary. Transfer of patients. Patients should be transferred to other organization based on their status, their need, or their own decision, to ensure that a continuity of care line is going on, continuum is going on. So that's the main thing about transfer of patient. Transportation. The hospital transportation services should comply with the state and the local laws, and transportation facilities should be provided by the hospital while transporting the patient to their home or to the next referral facilities. Patient's right and consent. Support patient dignity. There are total 11 rights and consents. The first thing is support your patient's dignity. Be respectful of the patient's personal values and beliefs. Respond to the request of spiritual and religious observance, if any. Right to privacy, confidentiality of care and information are respected. Protect the patient's possessions from theft or loss. Should protect the patient from any external physical assault. Inform the patients about all aspects of their medical care and treatment and their option of choosing no treatment. Participate in care and treatment decision. They have equal rights to participate in the care planning and treatment decision. Inform patients and families about their rights and responsibilities to refuse or discontinue treatment, withhold resuscitation services, or forego or withdraw life-sustaining treatment. So they have the right to not to DNR, do not resuscitate service, etc., and when to take them off life-sustaining treatment. So family members and the patients have their rights over these areas. Support the patient's right to assessment and management of pain and respectful, compassionate care at the end of life. Every patient has a right to get respectful and dignified end of life care. Inform the patients and families about its process to receive and to act on complaints, conflicts, differences, opinions about the patient care, and patient's right to participate in these processes. They have the right to put their grievances in front. If they have any complaint, we have the right to listen to their complaint and address it. General consent. It is obtained when the patient is admitted as an inpatient or is registered for the first time as an outpatient. It should be clear in its scope and limits. So the general consent consists of, it is obtained by trained staff in a manner and language that is understandable by the patient. Informed consent should be obtained before surgery, before anesthesia, procedural sedation, when you are using blood or blood products, and other high-risk treatments. Consent is obtained. Patients and families receive adequate information about the patient's condition, proposed treatments, procedures, so they can grant consent to make such decisions. Patient and family education. So what happens here is the hospital provides the education that supports the patient and family participation in care decision and care processes. Patient and their family members are an important part when it comes to making a holistic health decision along with the healthcare team. Each patient's educational needs are assessed and recorded in his or her medical record. You do not give a diabetic diet care plan to a hypertensive patient and vice versa. According to their medical needs, health education is provided. Patients and families' ability to learn and willingness to learn are assessed. You don't enforce health education on them. If they're willing and they want to learn, health education should be given. Verbal information is reinforced with written material. Along with verbal, written material is also provided. Educational methods may vary from in taking into account the patients and their families' preferences, and which allows sufficient interactions among the patient, family, and the staff who is giving the education. So it depends upon what kind of educational method you are choosing here. Quality standards for nutrition therapy. A variety of food choices appropriate to the patient's nutritional status and which is consistent with his or her clinical care and beliefs should be available always. The patient at nutrition should receive nutrition therapy. Who is required to have specific nutrition facilities to provide that particular nutrition therapy should be imparted. Prior to the patients being fed, all inpatients have orders for food in their medical records, which has to be followed, and the same has to be communicated to the dietary department to make arrangement for that particular nutritional diet. Order is based on the patient's nutritional status and needs. For diabetic patients, diabetic diets are there. Hypertensive patient, hypertensive diets are there. The distribution of food is timely and special requests are met, if any special requests. For example, maybe due to some religious or some beliefs and values, they may have to meet the special request of the diets. When families provide food, they are educated about the patient's diet limitations. When after this happens just before the discharge process, food provided by family or others is stored accordingly under proper conditions to prevent contamination. Quality standards for pain management. So identify the patients with pain during initial assessment, before admission itself, and reassessment. And after identifying, pain management can be provided. Provide information to the patients about pain. After any procedure, pain is expected. So you have to inform that before the procedure. After this procedure, for this many days, you may suffer from pain here. That is quite normal. We will try to manage the pain with pain medications. Such information has to be provided before hand. And communicating, um, providing management of pain, the treatments depends, IV, oral, or any hot application, cold application, whatever is the mode of pain management treatment, you can follow that. Communicating with and educating the patients and families about the pain symptom management in context of their personal, cultural, religious belief. Even after discharge, if the pain may continue in some cases, educate the families how to contain it. And educating the healthcare workers also about the pain assessment and management, pain skill reading, assessment and management. Quality standards for end of life care. To optimize the patients, the main purpose of quality standards here is to optimize the patient's comfort and dignity, ensure that symptoms will be assessed and appropriately managed, ensure that terminally ill patients will be treated with dignity and respect, assess patients as frequently as necessary to identify the symptoms of death, plan preventive and therapeutic approaches to manage symptoms. Wherever you can manage symptoms for a dying patient, try to manage that. Educate the patients and staff about managing symptoms. The hospital provides health end of life care for the dying patients that addresses the needs of the patient, the family, and optimizes the patient's comfort and dignity. Staffs are educated about the unique needs of the patients and families at the end of the life. Most probably, it will be some religious rituals they may have to perform before the patient passes away. So those needs should be met. Quality standards for organ and transplant, tissue transplant services. The hospital leadership provides all the resources to support the organ and tissue transplant. A qualified transplant program leader should be there, and they are responsible for the transplantation program. It is a multidisciplinary team that consists of people and with expertise in the relevant organ specific transplantation program from all the different departments. And it's a designated coordinating mechanism of transplant activities that involve physicians, nurses, other healthcare practitioners, counselors, etc. Organ-specific transplant clinical eligibility is there, in which psychological eligibility, social suitability criteria for the transplant candidates, everything is checked and priority is given to the person who most necessarily needs it, given to the critical medical condition. Informed consent. Transplant program obtains this informed consent specific to organ transplantation from the candidates. Then documentation. Documentation has some protocols which has to be followed. Clinical practice guidelines, procedures for organ recovery, organ receipt to ensure that it is compatible, safe, efficient, and the quality of the human cells receiving for transplantation, it is good. The tissues and the organs for transplantation, the efficacy, it is infection free. All this assessment has to be done. And finally, individualized patient care plans. It depends upon not two transplant patients may have the same care plan. Depending on the age factor, the risk factor, care plans may vary from one patient to another. So every transplant patient's care plan is individualized. So when you're using living organs, you have to adhere to the local laws and the regulations. As we have in India, we have Human Organ and Tissues Transplant Act of 1994. Such regional and local laws and regulation has to be followed. Informed consent should be taken with proper counseling, following proper counseling of the candidates, etc. Quality standards for transfusion products. SOP should include all the standards operating procedure should of the blood transfusion should include Patient's consent for administration. The patient who is going to receive the blood should consent for administration. Some religious beliefs do not allow, values do not allow blood transfusion or organ transplantation. So that has to be considered. Procurement of blood from blood bank and blood storage area. You have to check for compatibility, RS positive or RS negative antigens, etc. should match. These all things should be done from the blood bank before dispatching the blood products or blood. Patient identification should be checked twice before administering any blood production. At blood administration, check the vitals, keep a note on the vitals of the patient while he or she is receiving the blood. Monitoring of the patient, continuous vitals monitoring should be done. Identification and response to signs of potential transfusion reaction should be done. Do not directly leave the patient after putting him on blood, him or her on blood transfusion. Proper identification to check any allergic reaction, to check to any deteriorating condition should be looked out for. Anesthesia and surgical care. Anesthesia and procedural sedation are commonly viewed as a continuum from minimal sedation to full anesthesia. Standards are applied in whatever setting anesthesia or procedural sedation are used. So quality standards for anesthesia and surgical care. These services are available to meet the patient's need and meet professional standards and applicable to local and standard national standards, laws and regulations. A qualified individual is responsible for managing the sedation and anesthesia services. In sedation care, there is a standardization which has to be followed. Qualified professional should be there. Only they can administer the sedatives and the anesthesia, administered and monitored according to the guidelines. Even when the patient is under anesthesia, vitals are continuously being monitored. The risk, benefits, and alternatives related to the procedures of sedation are informed to the patients and the patient party so that they can opt out of the procedure if they wish to. In anesthesia care, pre-anesthesia assessment and pre-induction assessment is done. Planning and documentation of each patient's anesthesia care is done so that the reports can be made for the discharge. Risk, benefits, and alternatives related to the anesthesia are informed to the patients so that they have a choice. Monitor physiological status before administering the anesthesia and during the anesthesia, during when the patient is in anesthesia. Monitor and document the post-anesthesia status before you send the patient to the post-operative ward. In surgical care, planned and documented based on the assessment and based on the results of the assessment. The risk, benefits, and alternatives are informed again in surgical care. Document the surgical process, how successful it was, how the patient responded to the surgical procedure, etc. Plan and document the post-surgery patient care, even after discharge, what the patient has to follow at their home for self-care, that has to be also informed. Surgical care that includes implantation should be documented. So this is a WHO surgical safety checklist. Before induction of anesthesia, you have to confirm the identity, site, procedure of the patient, site marked not applicable, anesthesia safety checklist completes, pulse oximetry. Does patient have any known allergy, any risk of airway aspiration, any risk of blood loss? Everything should be completed. Before skin incision, confirm every team members have introduced themselves, the team members participating in the surgery. The surgeon has verbally confirmed the patient's site and site of surgery and procedure. Any anticipated critical events, are you ready for that? The surgeon reviews it, anesthetic team reviews it, and the nursing team reviews it. Any antibiotic prophylaxis has been given in the last 60 minutes, it has to be marked. Before the patient is sent for the post-operative, leaves the operating room and sent for the post-operating, nurse verbally confirms the team, check that the instruments count are there, so that there is no risk of leaving some instrument within the patient's body. How specimens are labeled, including the patient name, etc. So these are the parameters that has to be checked and filled for the WHO
surgical safety checklist. Quality standards for medication management and use. So, organization and management. The medication used in the hospital is organized to meet the patient's needs, complies with the applicable law and regulations, and is under the direction and supervision of a licensed pharmacist. Okay, this has to be kept in mind. And antibiotic stewardship is there or not? Is it being implemented everywhere or not? That has to be checked. In selection and procurement of medication, medications for prescribing or ordering are stocked. There is a process. If the medication are not stocked, normally available to the hospital for times when in need, the pharmacy is when the pharmacy is closed and you require a medication, what alternative you have for procurement, those steps should be mentioned. And regularly checking the inventory. Storage should be stored properly and safe out of the reach of the general visitors. And all the high risk medications, the narcotics, the dependable medications, everything should be stored in lock. Who is in charge of the key? Key will be on the rotational duty with whom. Everything has to be documented. Ordering and transcribing there are policies and procedures for ordering and transcribing. The hospital defines the elements of complete, if the order is complete or not, and identifies the individuals who are permitted to prescribe medications and all. Preparing and dispensing, say in a safe and clean environment only you can prepare and dispense the medication. Medication prescription or orders are reviewed for appropriateness. Audits are done on this area. A system is used to safely dispense the medication in the right dose to the right patient at the right time, etc. So that has to be taken care of. Administration, again, the hospital identifies those qualified individuals permitted to administer the medication. Medication administration includes a process to verify the medication is correct or not based on the medication prescription and order. In monitoring, hospital establishes and implements a process of reporting and acting on any medication or errors, any near misses, or any events that have led to allergic reaction or misreaction, etc. Evaluation, medication errors are evaluated on a regular basis and reported so that it doesn't take place again and again. Thank you.